CLL. And I wish that I could come up here and tell you that we have a strategy at Penn that we've developed that has led to superior outcomes. But I'll try to do my best to talk about where we're going with patients who develop this unfortunate complication. We'll talk about historical perspectives, how to define Richter's transformation, risk factors, biology, management, and then a little bit about what's going on with Richter's in terms of patients who are failing BCR antagonists, and then maybe some new directions. And probably we could talk about Richter's and prognosis based on the first case that was presented in 1928 by Maurice Richter, who was from NYU in Columbia. And if you look at the actual report, the patient entered the hospital June 14th, 1926, and died July 6, 1926. So although things are not quite that bad, things are not markedly improved from the first case that was described. And of course, the name Richter syndrome or Richter's transformation was attributed not by Richter himself, but in, I think it was 1964, where there was evidence presented for a pathological large cell transformation of the disease, which is where the term Richter syndrome was first presented. So we'll talk a little bit about epidemiology. And there is some variation in terms of how common Richter syndrome or Richter's transformation is, but if you look across case series, it's somewhere between 1 in 10% or 1 in 11%. And that probably has a lot to do with the patients that are selected in terms of looking at epidemiology. Whether or not they're newly diagnosed, whether or not they've seen prior therapies before, really influences the biology of the disease and the incidence of the transformation. These are data presented in JCO where you can see. Can you take me back? Okay. Presented in JCO where you can see that, there's a separate pointer, okay. Where that some of the differences in terms of incidence may have to do with the fact that there are differences in the, how rigorous an approach is taken to prove that a patient has Richter syndrome. And there are certainly some patients with CLL that have an accelerated or an aggressive course that are thought to be Richter's and ultimately aren't proven to be so. So if you look here at the, the number of patients who actually had biopsy-proven Richter's based on, and as compared to suspected Richter's, there's a little bit of a drop. So overall, I would estimate about 5% of patients, 5 to 10% of patients will develop Richter's. Of those, a subset of patients will develop this Hodgkin transformation of Richter's. And there are two types of Hodgkin transformation. There's a type 1, which is the type which develops in the background of CLL. And then there's a type 2 with a typical inflammatory background. And there's, in terms of prognosis for the Hodgkin subtype, it's varied, but most people think that it's inferior to patients who develop de novo Hodgkin lymphoma. So the term Richter's transformation should be restricted to patients who have a transformation from CLL, although I think, if you look in the literature, the term is thrown around quite loosely sometimes for transformation from other indolent lymphomas. Most are the DLBCL subtype. It's more common in males. There's commonly a loose classic CLL immunophenotype that's associated with it, so it's not always perfectly the same as patients with CLL. Most patients who have Richter's are positive for p53 staining by immunohistochemistry. 85% express post-germinal center markers. 80% are clonally related to the underlying CLL, and that probably impacts prognosis significantly. 75% express an unmutated IGVH. And then a little bit more about the characterization of the Hodgkin variant. Only 10% are the Hodgkin variant of Richter, although that incidence may be increasing. And my own experience with treating the Hodgkin variant has been pretty dismal, especially for patients of late who've developed that evolving after ibrutinib or other drugs similarly. Two distinct variants. Again, I mentioned the classic Hodgkin variant and then a Richter's-like cells lacking a polymorphous background variant. Some people think the outcome is better than DLBCL, although that's not clear. These are data that were presented from the Mayo series between 2000 and 2011, median follow-up of 4 years. 2.3% of patients developed Richter's. 47% transformed prior to treatment. All patients, the incidence was 0.5% per year. After treatment, it appears to increase to double of 1% per year, and 5% of patients had a stereotype BCR. So risk factors for transformation. We'll talk about some clinical and biological risk factors. In terms of clinical risk factors, you can see from a multivariate analysis that lymph node size, bulky disease seemed to impact disease, as well as the absence of a deletion 13q by FISH. There are common biological predictors associated with Richter's when corrected for rise stage. And you can see here that, things that have already been discussed in terms of IgVH mutational status, ZAP70 status, presence of a 17p deletion, for example, seem to be associated with the development of Richter's transformation. Telomere length has been studied, although this is not something we can test in practice. And then if you look further in terms of unmutated IgVH, there's thought to be a fourfold increased risk of developing Richter's transformation, as evidenced here by two series. Stereotype B-cell receptors are associated with the development of Richter's. These are receptors that are considered stereotype when the CDR3 sequences display greater than 50% amino acid identity, more than 70% amino acid similarity, and an exact CDR3 amino acid length, quasi-identical B-cell receptor variable regions. About 1/3 of patients with CLL will have a stereotype B-cell receptor, and it probably provides evidence that antigenic stimulation leads to the development of CLL. And there have been some really interesting papers published in Blood looking at this specifically. This was already presented by Rick, but a stereotyped BCR by itself seems to have important prognostic significance for the development of Richter's transformation. Then when you start to combine that with IgVH status, mutated versus unmutated, you see the risk goes up tremendously. And then if you look specifically at usage of 439 combined with stereotype BCR, you can start to see a model where for patients who are using 439 and have a stereotype BCR, those patients have a tremendously increased risk of developing Richter's transformation. So then the question arises whether or not we're actually inducing this with chemotherapy, and Rick also touched on this earlier. Probably fludarabine by itself or an alkylating agent by itself doesn't really impact the risk of developing Richter's, but certainly that risk increases tremendously when you start to have combination chemotherapies with an alkylator and a purine nucleoside analog therapy. And then there are predictors of Richter's transformation in patients who are treated with chemoimmunotherapy, and probably the one that stands out the most are patients who have a deletion 17p. Well, the question has been raised anecdotally whether or not kinase inhibitors increase the overall incidence of Richter's transformation. And if you look at series that are non-randomized, you might start to think that there's a higher incidence of Richter's transformation in patients who fail a B-cell receptor antagonist like ibrutinib. There are data presented by MD Anderson across 127 patients. The incidence was 5.5%. From Ohio State, 5.8%. From combined patients treated with idelalisib, 0.8%. But probably the most compelling evidence that B-cell receptor antagonists do not increase the overall incidence of Richter's transformation are the randomized trials that have been conducted. And I highlighted two here from the ibrutinib series, frontline and relapse refractory. I could have also highlighted data from the randomized study of idelalisib plus rituximab, where there does not seem to be an overall increase in incidence of Richter's in patients just because they received an agent like ibrutinib. Well, what are some of the genomic events leading to transformation? And this was alluded to earlier. Patients who have a p53 abnormality or a p53 dysregulation at diagnosis or even pre-diagnosis when they have monoclonal B-cell lymphocytosis, this is a relatively rare event. Less than 5% of patients with MBL, less than 10% of patients with CLL. But then when you start to look at patients with Richter's transformation, you see that exceeds 60%. The same is true for Notch. At diagnosis, you see, or actually at pre-diagnosis, 5% Notch mutation. At CLL diagnosis, approximately 10. And then ultimately, when patients develop Richter's transformation, it's enriched at 40% of patients. And this is just data that had previously been presented about Notch mutations, present 10% at diagnosis. Most common recurrent mutations are in the PES domain, resulting in decreased deregulation and prolongation and stabilization of Notch1 intracellular signaling, 30 to 40% of Richter's patients. And these are just data looking at Notch in terms of increased incidence of Richter's transformation, wild type versus mutant. And this is a model combining Notch mutation with 439 usage of IgVH. And you can see the presence of a Notch mutation combined with a stereotype B-cell receptor has a significantly increased risk of developing Richter's transformation. Now, whether or not those are present at diagnosis or detected earlier on, and whether or not those could be intervened upon to decrease the incidence of Richter's is unknown at this point in time. There are other genes which I won't talk about in great detail, but there's this PRMT5, which was presented at ASH in 2014, protein arginine methyltransferase 5, which seems to be associated with the development of Richter's. And then there's genetic loss of NFAT2, which is associated with B-cell receptor signaling, which is also associated with an increased risk of Richter's. Well, how do we diagnose Richter's transformation? These are patients who typically present with aggressive features that one would see in a patient with large cell lymphoma or an aggressive B-cell lymphoma. They have fevers, they have rapid enlarging lymph nodes, weight loss, hypercalcemia, markedly elevated LDH, extranodal involvement. You can also see the same thing in patients who progress beyond B-cell receptor antagonists with this so-called aggressive CLL. I think anyone in the room who's recently treated a patient with Richter's transformation or ever treated a patient with Richter's transformation knows that the presentation is not subtle. These patients are sick and oftentimes require hospitalization at or near the time of diagnosis. Obviously, biopsy is required in order to confirm whether or not this is a DLBCL or Hodgkin subtype. There have been models proposed that can help guide where to biopsy a patient. And there are a couple of different series, actually several series published looking at PET imaging to help decide where biopsy should be performed or if a patient has Richter's based on SUV max. You can see with a cut point of 5 or higher, there's 91% sensitivity, 80% specificity. With a cut point of 10, 91, and 95% in terms of sensitivity and specificity, respectively, with a negative predictive value of 100%. So now I'll talk a little bit about prognosis, and this was also alluded to earlier, but there are risk scores that have been developed to help risk stratify patients with Richter's transformation. And there was a series published by the MD Anderson group looking at almost 4,000 patients, of whom only 148 had biopsy-proven Richter's, of whom 130 were actually treated. And what they did was identify 5 pre-treatment clinical characteristics that could help prognosticate patients. And those are listed here, including performance status, LDH, the platelet count, the tumor size, and the number of prior therapies. And you can risk stratify patients into groups, low to intermediate or high risk. And you can see that in a validated series of patients, the overall survival for patients here ranges from 8 months to 4.5 months. Now, whether or not you can intervene differently for a patient who has a low RS score versus a high IS score remains to be seen. Predictors of outcome to therapy include clonality and P53 interruption, and whether or not the Richter's transformation is clonally or related or unrelated to the underlying CLL impacts prognosis tremendously. If it's unrelated, you can sort of think of that as a de novo DLBCL in terms of prognosis. Not quite as good, but probably similar. If there's P53 interruption, which is in the vast majority of patients, probably close to 80%, those patients have an inferior prognosis. Without going into the detail, there are now prognostic scoring systems that have been developed which actually incorporate the molecular features of Richter's, specifically interruption of P53. And that PET imaging has also been used to discriminate highest risk. And if you have a SUV max of greater than 10, that is associated with Richter's. That's associated with an inferior survival as opposed to patients who have an SUV max that's less than 10. Well, what about treatment for Richter's syndrome or Richter's transformation? And across the board, people have tried to use combination chemotherapy or combination chemoimmunotherapy, and this isn't meant for comparison by any means, except to say that when you start to look at patients' survival and response rate, it's pretty dismal with combination chemotherapy, and most of the time patients will have a transient response and a limited survival, regardless of how dose-intensive a regimen is used to treat patients. And this series includes patients who had EPOC, who had hyper-CVAD, who had OFAR, you name it. Patients generally have a poor prognosis beyond R-CHOP, regardless of how intensive therapies are. There have been attempts to modify the regimen here with obinutuzumab, and you can see that the overall survival for patients is quite poor still with patients with Richter's transformation. The same is true for EPOC. There's also a question about the impact of stem cell transplantation on Richter's syndrome, and I think these data are one of the most important things to emphasize about these data, that they're incredibly biased. Number one, most patients with CLL are older, so they're not candidates for stem cell transformation. And then when you look at the series, you have to look at the numerator and the denominator. 148 patients with Richter's, of whom 20 were able to undergo stem cell transplantation. And then there are comparisons that are made looking at auto versus allo, and there's inherent bias there, in that patients who underwent allo transplant had more refractory disease than those who had auto transplant. And so in my opinion, there's a very limited role for stem cell transplantation in patients with Richter syndrome. If you can get a patient into a deep remission and they're young and they have a donor, it's potentially a curative intervention for patients, but that's the vast minority of patients. Well, what about outcomes after kinase inhibitor therapy? And this is obviously a very important paper, since in every presentation we've seen it so far from the Ohio State group. And these data suggest that Richters are occurring relatively early after exposure to drugs like ibrutinib, and that may be not so much the impact of on the biology of the disease, but the fact that these patients are heavily pretreated to begin with, and some of them probably had Richters before they enrolled on the pivotal clinical trials. There are also models that have been proposed that combine patients with Richter's transformation and CLL progression, suggesting, for example, that the presence of a BCL6 abnormality or a complex karyotype, and I would add to that a 17p deletion, increased the risk of developing Richter's transformation. Of course, the headline from these articles was the overall survival for the cohort of patients with Richter's. In the MD Anderson series that are presented here, it's 3.1 months. In the Ohio State series, I believe it was 3.5 months. We looked at our center and across the country at outcomes for patients who were treated with kinase inhibitors, and these are the reasons for discontinuation of a kinase inhibitor. And Richter's was about 11% of patients who discontinued a kinase inhibitor did so in the setting of Richter's transformation. There's a difference here in the progression-free and overall survival. Keep in mind that the series that were previously presented were patients who had biopsy-proven Richter's. Probably some of the Richter's in this series are patients with accelerated CLL, which is why the median progression-free and overall survival seem to be a little bit longer. I would still conclude when you're comparing it to patients who have toxicity or progression of CLL that it's far inferior. So what about ASH 2015 and 2016? Are there any encouraging data that may suggest an alternate treatment strategy for patients beyond chemoimmunotherapy and stem cell transplantation? There were data presented by the Mayo Clinic group looking at PD-1 blockade with pembrolizumab monotherapy. Very small number of patients treated with both CLL and Richter's transformation, enriched, of course, for patients with high-risk features like an 11q deletion, 17p deletion, p53 mutation, and unmutated CLL. This was the slide that got a lot of attention that was presented at ASH with the PET imaging, where the picture is telling a lot of the story. These patients were heavily pretreated. And you can see that although, again, small number of patients, total of 7, the patients with Richter's transformation in the swimmer's plot could obtain a durable response to pembrolizumab monotherapy. And so I think this is, although again, small number of patients, and at least in our practice, has induced a little bit of a paradigm shift in that we're thinking about incorporating anti-PD-1 agents in our treatment approaches for Richter's relatively early on. There's also phase 1-2 data presented for acalabrutinib, ACP-196, which is a next generation BTK inhibitor in patients with Richter's transformation. And again, relatively small number of patients, and there's modest activity of acalabrutinib, a response rate of 38.1%, although the responses were not particularly durable. We've looked in our own practice at a small number of patients who were treated with ibrutinib in the setting of Richter's who hadn't seen it before. And again, patients can respond, but the responses are generally on the scale of months. So I don't think BTK inhibition as a monotherapy will likely be the solution, but if they hadn't seen a BTK inhibitor before, there's probably some activity, potentially as a bridge to transplant or other cellular therapies. And then there were data presented at ASH, again, small number of patients in total of the PD-1 inhibitor nivolumab with ibrutinib for patients with CLL or Richter's transformation. I think the take home from the study was that PD-1 inhibitors can be combined with BTK inhibitors relatively safely. There were no grade greater than 3 immune-related toxicities. And if you look across the small number of patients, they had high-risk features, they were heavily pretreated, but if you look at the current status of patients, you can see that there are durable responses that are being obtained. And certainly when you get patients out 11 plus months, I think it's hard to attribute that to the BTK inhibitor, although that particular patient hadn't been exposed to ibrutinib in the past. At our center, we have a study for patients with CLL looking at the combination of TG1101, which is a CD20, with TGR1202, which is a PI3K inhibitor, in combination with pembrolizumab, so a triple therapy for patients with CLL and Richter's transformation that's accruing patients at Penn and at Fred Hutchinson Cancer Center. And we also have a study that includes Richter's, which is a first-in-human combination of a BTK inhibitor, IMiD, with mTOR inhibitor for patients with CLL and aggressive lymphomas. So in summary, Richter's is a distinct biological entity from de novo DLBCL and other transformed lymphomas, although transformation is associated with specific recurrent mutational, chromosomal, and promoter methylation changes compared to paired CLL samples. Clinical, biological, and genomic information is now established for the risk of Richter's transformation and potential predictors of outcome, although I can't say that there's any intervention I can present today that has changed the natural history of the disease, with maybe the exception of stem cell transplantation. Current chemoimmunotherapy paradigms are, I would say, essentially ineffective, except for patients who have an unrelated clone. Transplantation might improve outcomes, however, there's a few number of patients who are actually eligible or can have a response that's durable enough to get them to transplantation. And there are a few targeted approaches available, but the efficacy is not proven at this point in time, and certainly the targeted approaches are interesting and compelling, but not the standard of care. So I'll stop there, and thanks to John Allen, Emily Ayers, and Danielle Brander for some information. Thanks.